Good afternoon. Today we're going to discuss dermatological disorders or the pathophysiology of integumentary. So before we go into the disease processes, let's talk a little bit about anatomy. If you remember, the skin is considered the largest organ of the body since it has many different functions. The skin functions is thermoregulation, protection, metabolic function, and also sensation. We're going to discuss the divisions of the skin. Mainly, it's divided into two main regions, epidermis and dermis, but also the subcutaneous tissue or hypodermis is present. The dermis is attached to an underlying hypodermis, which is also called subcutaneous connective tissue, which basically stores adipose tissue and is recognized as the superficial fascia of gross anatomy. So here you have the epidermis, the dermis, and the subcutaneous tissue. You will see that the epidermis has many stratums that we will discuss. In addition, in the dermis, you have all the papillary layers with blood vessels. And in the subcutaneous tissue, you have basically the annexus. So let's talk first about the epidermis. And here are the stratums that relates to the epidermis. The epidermis is the most superficial layer of the skin and provides the first barrier of protection from invasion of foreign bodies, substances, as well as infectious and inflammatory processes. The principal cell of the epidermis is called keratinocyte or keratinocyte. The epidermis is subdivided into 5 layers or strata. You have the stratum germinatum, you have the stratum spinosum, stratum granulosum, and stratum lucidum. In other books, it's divided is basically the same. The germinatums will be the corneum. So the stratum corneum, the stratum granulosum, which is the second layer. You have the stratum spinosum and the stratum lucidum or basale. Keratinocytes gradually migrate to the surface of the skin once the skin starts to slough off in a process called dequamation. Now let's discuss the stratums. We have the stratum corneum, where the keratinocytes and melanocytes are present. If you remember, melanocytes is the cells that produce melanin, located in the bottom layer of the stratum basalus in the epidermis. If you remember, the main function is the, again, production or the metabolism of melanin. Numerous stimuli are able to alter the melanogenesis or the production of melanin. And these are vitamin D, melanocyte stimulating hormone, because melanin also pertain to the hypothalamus hypophysis axis. There's also stratus basale, stratus spinosum, stratum germinatum. The cells that are present in the in these stratums are the melanocytes that we already discussed. In addition, the Langerhans cells, which are dendritic cells. These are the antigen-presenting immune cells of the skin and mucosa. That also contains organelles, all the organelles that any other cell has, which pertains to the first day of class, the eukaryote type of cell. Okay, and the Langerhans cells are basically predominant in the stratum spinosum. Again, the Langerhans cells are immune defense. They're dendritic cells that participate in antigen presentation. In addition, there is Merker nerve ending, which is another type of cell, which are basically mechanoreceptors that are found in the basal epidermis and hair follicles. They're classified as slow adapting type 1 mechanoreceptors, and they also have nerve endings at the level of the myelin sheath. They provide pressure, position, static features of shape and edge. I'm sorry. Basically, these are the main functions since they are nerves. In addition to that, they are able to sustain a response of the action potential by mechanically perceive touch and vibration. So whenever the skin is touched and there is sensation of vibration, these mechanoreceptors are stimulated. In addition, in the dermis, there is connective tissue, which is collagen present, elastin, reticulin, and in addition, hair follicles start at that level. Sebaceous glands are present, divided into apocrine and eccrine glands. The dermis assumes the important function of thermoregulation and also supports the vascular network to supply the avascular epidermis with nutrients. Because remember, the epidermis has no vessels. The dermis is typically subdivided into two zones, the papillary dermis and reticular layer. The dermis contains fibroblasts, which are responsible for secreting collagen, also elastin, as I said before, and ground substances that give the support and elasticity of the skin. Also present in the dermis are immune cells that are involved in the defense against foreign invaders passing through the epidermis. In addition, there is mast cells that participate in the hypersensitivity reactions that we already discussed, and also macrophages that participate in phagocytosis. The skin appendages that I mentioned before, there are hair follicles, sweat glands, and sebaceous glands. Now, subcutaneous tissues is basically connects the dermis to the underlying muscle. The main cell is adipocytes. They also have a very good rich supply of capillaries and venules, and in addition there is AV anastomosis present. It is innervated by the sympathetic nervous system and also is rich of lymphatic vessels. Now, let's discuss what happens with skin integrity during aging. If you could see, there is a decreased strength due to decrease of elastin and decrease of collagen, so therefore there is susceptibility to scoriations and blisters, bruising. There is fragility of the skin as well as the blood vessels. There is in addition increased risk for petechias and purpuras, disruption of the skin by friction. There's also impaired skin barrier, so patients would have more dryness, and this dryness will dehydrate the skin, leading to pruritus and excoriations. There is also increased injury with from tape and also chemical and drugs as well, maceration of the skin. There is autoimmunity, so the patients are more predisposed to cancers and lymphomas. There is also senescing, which is slow cell turnover with slow and complete skin and wound healing. So patients would have abnormal DNA and atypia. There's more predisposition for impaired apoptosis, so therefore neoplasms could be present, like squamous cell carcinoma and melanomas. Um, Skin appendages and vascular problems could be present, so patients have a grain of hair, thinning of the skin, as I said already, reduced capillary perfusion, changes with thermoregulation. In addition, there's decrease in skin protective functions as well. So patients are more susceptible to sun damage, irregular pigmentation, they're less aware of pending skin damage. So many times they have a trauma or a laceration of the skin and they realize once they're already bleeding or someone tells them that they just suffer a contusion of the skin or skin tear. Now, you need to know these slides coming up. Memorize the definition of these primary and secondary lesions. Macule. What is a macule? Basically, a macule is no more than a spot or stain in the skin. Is basically a changing color of the epidermis. It is flat and it is less than 1 centimeter of diameter. So if you see a regular non-raised spot, it could be different colors. It could be white, it could be brown, it could be black, it could be purple, it could be red. It doesn't really matter the skin, the color, but it's a changing color of the epidermis when it's less than 1 centimeter and it's not raised, it's flat. Papule, on the contrary, has the same diameter, but it is raised. So it is small, solid, rounded bump rising from the epidermis. So if you look at the skin in a 15 to 30 degree angle, you're able to see that this lesion rises from the epidermis surface. A vesicle is no more than also less than 1 centimeter diameter. It is also an elevation from the epidermis, the same as the papule. The difference is that the papule is solid and the vesicle is full of fluid. It's like a small blister, but it's not a blister because a vesicle is less than 1 centimeter and a blister is more than 1 centimeter. A pustule is no more than the same as a vesicle, but instead of being filled with clear, transparent serous fluid, is filled with pus. So it's also less than 1 centimeter. It's also an elevation of the epidermis, but contains pus. Continuing with the primary lesion, if a macule is no more than a stain less than 1 centimeter flat, the patch is the same, but more than 1 centimeter diameter. If a papule is small, solid, round, less than 1 centimeter diameter, solid, above the epidermis, the plaque is the same but more than 1 centimeter diameter. What's the difference with a nodule and a papule? Besides the diameter, that the papule is less than 1 centimeter and the nodule is more than 1 centimeter. So what would be the difference between a nodule and a plaque and a nodule and a papule? Well, first diameter, and second that the plaque rises from the epidermis and the nodule rises from the dermis and the subcutaneous tissue, so it's deeper. The actual root of the nodule is deeper. A bulla is no more than a blister. So if a vesicle is less than 1 centimeter with serous fluid, the bulla or blister is the same thing, but more than 1 centimeter with serous fluid. Now let's talk about secondary lesions. Secondary lesions could be done by distortion of the primary lesion, for example, by scratching, or if a blister, if a blister or a vesicle ruptures, it could convert into an ulcer or drying up of that serous fluid that comes out and becomes a crust. So most of the time secondary lesions are produced as consequences of distortion of the primary lesions. So what is an erosion? Erosion is the discontinuity of the skin exhibiting incomplete loss of the epidermis. So if you're now biking or you're running and you fall, that friction burn on your knees is an erosion. Ulcer is also an erosion of the skin or the mucous membrane, but has more tissue disintegration than an erosion. If a blister or a vesicle ruptures, the center of that blister, the cavity, the floor of that blister or vesicle, it could become an ulcer. Fissure is no more than a crack or a cleft. It's no more than a long, narrow opening of the skin. So if your skin is very, very dry and you stretch that skin, it could become a fissure. Excoriation is no more than what you produce on the skin by the process of scratching. So it's linear abrasion, is a mechanical mean of disintegrating the skin or the epidermis by scratching. Now if you continue to scratch, you could go deeper into the dermis or even subcutaneous tissue, and when that heals up by a process of fibrosis, it becomes a lichenification that is coming after. Lichenification, okay? What's a crust? That fluid that comes out from a blister, or the fluid that comes out from a pustule, or the fluid that comes out from a vesicle, when dries up, is a crust. It's no more than dried off substance or fluid. It could be serum, it could be pus, it could be blood that comes out from a primary lesion such as a vesicle, such as a blister or bulla. It could contain bacterial infection or superimposed infection. Again, lichenification is no more than that epidermal thickening after the healing process. When you continue to scratch and you start producing excoriation after excoriation, and that heals up, that thickening of the epidermis is a lichenification. Atrophy, we already discussed what an atrophy is, which is thinning of the skin, or in other words, is basically decreased cell size. Okay, scar is what is left off when you affect the surface of the skin. Lichenification is a type of scarring process, but a scar is also when you had an incision due to surgery, or when you had a burn, and that mark that is left after the healing process is a scar. A keloid is no more than an hypertrophy of the healing process of the skin, which is sharply elevated, has a regular shape, and excessive collagen formation. Scale is no more than when you have dry skin, or by a process, for example, fungal infection, that there are flakes of dry epidermis. That's a scale. Okay, examples of a macule. That's another macule. If you pass your finger through the surface of this lesion, it's flat, it's not raised, compared to this mole that if you pass your finger above that mole, it is raised. So this is a macule, another macule, which is white, it doesn't matter the color, remember, and this is a papule. This is a patch, because if you measure this, it's greater than 1 centimeter. This is a plaque, because it's raised. If you pass your fingers above the border or across the border of this erythema, it is raised. So this is a patch, this is a plaque, and these are nodules. They're very deep. They go into the dermis and the subcutaneous tissue. You have also hives, you have a blister, You have pustule that has pus inside. You have vesicles. So you see, look at the diameter of this vesicle and look at the diameter of this one. So this one's greater than 1 centimeter, so therefore it's a bulla or blister, and this is a vesicle. You could consider this as, if it's very small, as a papule. When it's very big, you could consider that as a plaque. Nodule, these are telangiectasias. These are excoriation by scratching. I don't know if you were able to see the linear formation of the nails by scratching, and this thickening of the epidermis by scratching is called liquenification. Now let's talk about pressure ulcers. Pressure ulcers are very areas of necrosis and ulceration where tissues are compressed between the bone prominence and hard surfaces. They're caused by pressure in combination with friction, aging, shearing forces, moisture. Main risk factors, talking about aging, is greater than 65 years old, impaired circulation, chronic diseases such as diabetes and peripheral vascular diseases, immobilization, undernutrition, incontinency, sensory impairments such as patients that have cerebrovascular accident, diabetes, or neuropathies. In addition, severity ranges from non-blanchable skin erythema to full thickness skin loss with extensive soft tissue necrosis. If you remember the stages of the pressure ulcers, stage 1 is basically a non-blanchable redness. Stage 2 is partial thickness loss of dermis. Stage 3 is full thickness tissue loss that goes into the subcutaneous tissue. May be visible, but bone tendons or muscles are not exposed. Stage 4 is also full thickness tissue loss, but with exposure of bone, tendons, or muscles. And unstageable is the full thickness tissue loss, in which the base of the ulcers is covered by slough, yellow, tan, gray, green, or brown scar. If we talk about the pathophysiology of pressure ulcers, mainly contributing factors are when pressure, friction, shearing forces, and moisture. When soft tissues are compressed between the bone prominence and the contact surfaces, microvascular occlusion with tissue ischemia and hypoxia occurs. If compression is not relieved within the 3 to 4 hours, and again, of course, most commonly that occurs in the sacrum, in the ischial tuberosities or malleolus or the heels, this erythema non-blanchable starts. Friction, basically when rubbing against clothing or bedding, can help trigger skin ulceration by causing local erosion and breaks the epidermis and superficial dermis. Shearing forces, when a patient is placed on an incline, stress or damage supporting tissues by causing forces of muscles and subcutaneous tissues that are drawn down by gravity to oppose the more superficial tissue remains in contact with external surfaces. So this could cause pressure ulcers as well. Moisture, when the patient is incontinent or when there is severe perspiration, that also leads to maceration and tissue breakdown. These are the different stages up to non-stageable. Okay, so now let's talk about the symptoms and possible complications before we go into dermatitis and eczema. The main complication, the symptoms, is basically the staging process that we already discussed, and the complications are hospital acquired infections because the patients could become septic, osteomyelitis could be also present, and not only local or sepsis, but also these patients could become bacteremic, and endocarditis could occur. You would see in pharmacology how you have to manage this by basically pressure reduction, by protecting paddings. Um, in addition, many medications that are used to for mechanical debridement, the way to dry dressings, autolytic debridements, and enzymatic debridements that we will discuss in pharmacology. Now let's talk about dermatitis. Dermatitis is a superficial inflammation of the skin that is characterized by redness, edema, oozing, crusting, scaling, vesicles, and pruritus, of course. Pruritus is common, very, very common, and eczema is a term often used interchangeable with dermatitis, but is sometimes used synonymously with atopic dermatitis. So it's an inflammation of the skin that has the same characteristics of generalized dermatitis, and patients have a serious discharge matter coming from the main primary lesions. Now let's talk about atopic dermatitis. Patients with atopic dermatitis have an immune-mediated inflammation. If you remember, this belongs to hypersensitivity reaction type 1 that arises from an interaction between genetics and environmental factors. Patients with atopic dermatitis have a history of asthma, hay fever, or food allergies themselves or family members, first generation, such as mothers, sisters, brothers, aunt, grandma, or grandpa. The genetic factors involve both the epidermis barrier function as well as the immune system. Etiology, again, affects everybody, but is very common in pediatric population. Prevalence is in children, 20%. Most people with the disorder develop this before age 5. Again, many family members have allergic rhinitis as well. The main pathophysiology of atopic dermatitis is extrinsic IgE mediated, or intrinsic, which less common, of course, has nothing to do with allergic reaction, but the most common, like 80%, have a history of asthma, hay fever, and allergic rhinitis and food allergies. Many patients have a mutation with gene encoding a protein that is present in the skin at the level of the stratus corneum. So there's a reduced stratus corneum lipid layer and alteration of the filaggrin protein that is present in the skin that impedes water loss and impedes this hypersensitivity reaction. So these patients with atopic dermatitis would have a transepidermal water loss and eosinophilia due to this major IgE mediated reaction. So you would see that they have a very dry skin and they have a big amount of pruritus. Very common in dry climates. Common environmental factors are foods such as milk, eggs, soy, peanuts, fish, airborne allergens such as dust mites, mold, dander, Staphylococcus aureus is also present, as well as cosmetics, for example. The main symptomatology is itching, is the hallmark, is pruritus, redness, edema, scaling. Infants, most commonly present in the face, in the scalp, in the trunk, and in the extensors. In the extensor surfaces, so anteriorly at the level of the antecubital flexure, and also behind the popliteal flexure, as well as in the neck, in the cheeks, They have scratching and rubbing, erythema, um, up to lichenification if you don't stop the circle, the vicious cycle of pruritus and scratching. So again, antecubital and popliteal fossa in the eyelids, in the neck, in the wrist is also present. If you look at this baby, is in the cheeks, in the neck. This is the antecubital area. This is very atypical in the knees, but normally it's not there. If you look at this schema, is in the forehead, in the eyelids, in the cheek, in the neck, in the antecubital, in the wrist, in the groins, and in the ankles, and the posterior area of the knee. So popliteal fossa. This is the popliteal fossa. Okay. You will learn about treatments in pharmacology. So let's continue with contact dermatitis. Contact dermatitis is also an inflammation of the skin, but it's caused by irritants or allergens. You have to be exposed to something. It's not systemic. It's not because you have a history of family members or yourself of asthma, allergic rhinitis, or hay fever. This is because you were exposed to an irritant or an allergen. Okay? The primary symptom is also pruritus. It's a hypersensitivity reaction type 4, even though patients also have IgE increased. It is also environmental, so if you're exposed to poison ivy, to the plant, you could develop a rash. If you're exposed to, for example, neomycin present in triple antibiotic or any type of topical antibiotic over the counter that has neomycin as main ingredient. If you're allergic to nickels, fragrances, latex, for example, nurses that are allergic to latex and you use gloves, you could develop contact dermatitis. The beauty of contact dermatitis is that you're able to identify the prior irritant or allergen that was present most of the time. If you have an erythema with multiple lesions in your hands and a lot of pruritus and is bilateral symmetric, and only at the level of the hands, you could predict that this patient had gloves prior to that. If you have, for example, pair of earrings, or any type of jewelry that has nickel on it, and was in direct contact with the skin, you could predict that this patient had possibly a new pair of earrings in their earlobes, and that's the reason why you have redness and itching and oozing at the level of the earlobes, or a chain, for example. So the pathophysiology is mainly caused by irritants or allergens. 80% is a non-specific inflammatory reaction to substances contacting the skin. The immune system is not mainly activated. So this is not due by a systemic reaction of allergies. Chemicals such as acid, alkalines, solvents, metal salts. When the new soap, foaming soap that came out in the hospitals for us to do a very good hygiene, hand hygiene, you would wash your hands, you would get in contact with this foam or the alcoholic material to rub your hands. Many nurses were allergic to that, so you could develop a contact dermatitis due to that, due to plants, due to pepper, or body fluids, as you could see here in diaper dermatitis. The problem is that the irritants could have an extreme pH, or environmental, such as low humidity and high temperature or friction. Patients that are very young or very old, or when they're exposed to their own urine or feces, they could develop this contact dermatitis. It's a type 4, as I said, cell-mediated hypersensitivity reaction that patients are sensitized to the antigen, and then they develop a response after the re-exposure. Symptoms and signs, as I explained, very pruritic. It could cause erythema, erosion, pustules, edema. But the best is that it is bilateral and symmetric. So, for example, you could tell that this patient is allergic to nickel. Or maybe this patient had a wax done and developed a contact dermatitis after a wax. This patient had most likely nickel also or aluminum exposed. This is basically an orthopedic brace. So patient developed an allergy. You could tell the pattern. Or bilateral, hands due to glove. Again, this is pertinent to pharmacology, but since it's an immune reaction, most of the time irritant, type 4, you have to provide steroids, and it's topical steroids is the mainstay of treatment. It could be systemic, but most commonly is due to an allergic and irritant reaction. So for atopic dermatitis as well as for contact dermatitis, it's best to treat with antihistamines due to mastocyte degranulation and IgE released in type 1, which is for atopic dermatitis, or as well as topical steroids for both in atopic and contact dermatitis, since this is an inflammatory reaction. Now, if it doesn't work, you could go up to immunosuppressive, but it's rarely necessary. You could use cool compresses, oatmeal bath, boron solution, prevent dryness of the skin, because the drier the skin, the more itching, and the visual cycles continues. If we go back here, diaper dermatitis is also a type of contact dermatitis due to a prolonged exposure of urine feces, producing a maceration. Okay, that could obtain as superimposed infection, candida, and you could see this redness of the skin with satellite lesions produced by candida albicans. Okay, we talked about the treatment. So now let's talk about other types of dermatitis, and we have seborrheic dermatitis. Seborrheic dermatitis is also an inflammation of the skin region. This is dandruff, okay, that is basically present in sebaceous gland that could be affecting, it could affect the face, the scalp, the upper trunk, the glabella, and also the eyebrows. The cause, again, is a fungi. Is called Malassezia. You don't need to know the name of that. But basically it's a fungi. And of course, patients that are immunodepressed, such as diabetes or any autoimmune disease, or patients that have HIV, or using an irritant for your scalp, could produce dandruff. Occurs very, very common in infants, usually within the first 3 months of life, but also could occur between the ages of 30 to 70. The incidence and severity of the disease seems to be affected, as I said, could be emotional, physical stress, the climate, very hot weather or cold weather, but also patients that have immunosuppressive diseases. The symptoms develop gradually. You're able to see a red, greasy looking yellowish scale with mild pruritus that could be present in the hairline, in the scalp, in the eyebrows, in the T-zone, which is called glabella, ears, and also the sternum. Newborns develop a thick, jello-crusted scalp lesion called cradle cap, I'm sorry, Cradlecap. So cradle, cap. It could produce fissures, yellow scaling, up to a very thick, tenacious scale that you could actually remove, then could bleed. Treatment wise, shampoo with azoles, which you would see in pharmacology, itraconazole, ketoconazole, which is nizoral shampoo, and also steroid creams. Now let's talk about another disease. I have pictures after this slide. If you come here, this is seborrheic dermatitis. You could see the yellowish scale present. This is in the scalp. This is in the eyebrows. This is the T-zone or the glabella. Okay, this is in an adolescent. Now let's talk about pityriasis rosea, which pityriasis rosea is basically tends to be self-limited. It's a viral condition. Many patients have a prior history of flu-like symptoms. So since it's self-limiting, it doesn't require treatment most of the time. Very common in the winter season. Common in the ages of the 10 to 35, affects mostly women. It's caused by a viral infection, but it could be also related to autoimmune disorders. And the symptoms, classically, patient begins with a single patch, which is called Harrow patch, that appears most of the time in the trunk or proximal limbs. And then after that, a centripetal eruption or rash, which have fawn color oval papules and plaques, follow within the 7 to 14 days. It appears to be like a collarette type of eruption or Christmas tree distribution. Patients also could complain of malaise, headache, arthralgias, like flu-like symptoms, and then the rash appears. If you look here in these pictures, you have the single lesion that tends to appear first in the trunk or in the lower extremities, and then after that, like lesions surrounding the Harrow patch that could be more extensive in the trunk, in the upper arms, and in the legs, appear after that. Then you have lichen planus, which in lichen planus, this is a papulus camosus purple lesion. Is recurrent pruritic inflammatory eruption characterized by small discrete violets, like purple papules, that may coalesce into bigger plaques, often accompanied by oral or genital lesions as well. The etiology of the lichen planus is an autoimmune disorder. Is believed that it's a reaction against basal epithelial keratinocytes by a genetic predisposition. It is linked to emotional stress. It is linked to hepatitis C. So all these patients must be worked up first before you could say this is stress related. It could also be related to drugs such as NSAIDs, ACE inhibitors, sulfonylureas, thiazide diuretics. Also could be related to patients that have lupus, hepatitis C, hepatitis B, liver dysfunction such as cirrhosis of the liver. And again, very typical lesions are pruritic and they're purple. If you look here, this is lichen planus. Okay. Now let's talk about psoriasis. Psoriasis is also an autoimmune problem. It's inflammatory disease that manifests most commonly by a well-circumscribed erythematous papules and plaque that are covered by a silver scale. That's very pathognomonic. It is thought that it's a T-cell mediated autoimmune disorder, is cellular hyperproliferation of epidermis and keratinocytes combined with inflammation of the epidermis and dermis. The common triggers are trauma, infections, and certain drugs as well. So if a patient has an injury, the plaques continue to expand. This is called Koebner phenomenon. Koeb as in boy, N-E-R phenomenon. Triggers others than the one already mentioned could be emotional stress, alcohol consumption, tobacco abuse, HIV, as well as medications such as beta blockers, ACE inhibitors, indomethacin such as NSAIDs previously stated, and lithium. The main symptoms are well demarcated, thick, silvery, scaly plaques. They're asymptomatic. They could be a little pruritic or itchy. This could be present as well in the nails, in the eyebrows, in the axilla, in the perineal area, but very, very common are present in the extensor surface. Remember that atopic dermatitis is present in the flexure area, so antecubital and popliteal fossa. Psoriasis is completely inversed. It's present in the knees and the elbows. Now, you could have a disseminated psoriasis that is called psoriasis guttata. But the one we're talking about is plaque psoriasis or psoriasis vulgaris. Okay, and you treat it with emollients, steroids, UV light, and immunomodulators, but that's topic of discussion for pharmacology. This is the plaque that is covered with a silver scale. This is psoriasis guttata, which is more generalized. Now let's talk about acne. Acne is basically a disease of the pilosebaceous unit that basically is produced by blockage of skin pores with dead skin. It's formation of comedone, papules, pustules, and nodules as a result of an obstruction and inflammation of the pilosebaceous units, which are the hair follicles, and the sebaceous gland. The pathophysiology of acne occurs through an interplay of major factors. There is excess of sebum, as theory, follicular plugging of sebum and keratinocytes. There's also colonization of Propionibacterium acne. There's release of multiple inflammatory mediators. Acne could be classified as inflammatory or non-inflammatory. If it's non-inflammatory, you will be able to see the comedones, which basically are open or closed comedones that has skin surface inside the follicle. And the inflammatory is the pustules, the nodules. Etiology is basically most common trigger is puberty, but others could be hormonal, close to the menstrual cycle or during pregnancy. Occlusive, it could be due to cosmetics or cleansers or lotions that are non-comedogenic. That are comedogenic, so you have to look for creams or lotions or cosmetics that are labeled non-comedogenic to avoid clogging your pores. Signs and symptoms, basically patients have skin lesions and scarring. That can be a source of significant emotional stress because patients continue to pick at them. Comedones appear as whiteheads or blackheads. Patients could have papules or pustules and even nodules and cysts. Okay, so there is follicular hyperkeratinization and Propionibacterium acne, and also excess of testosterone. Rosacea is another disease process that we will discuss. And basically rosacea, let me show you the acne. This is the acne. You're able to see pustules here and papules. Okay. On the contrary, this is rosacea. So let's talk about rosacea now. Basically, it's a chronic inflammatory disorder that is characterized by facial flushing, telangiectasias, which are spider veins in your face, erythema, papules, pustules, and in severe cases, the nose will produce hypertrophy, which is called rhinophyma. The etiology of rosacea is an abnormal vasomotor control. That's the pathophysiology that impairs facial venous drainage. In addition, there is increased bacterial infection, which is called Demodex follicularum. There is increased angiogenesis, so therefore patients have telangiectasias or spider veins in their face, and dysfunction of the immune system that prevents superimposed infection. Patients would have flushing accompanied by uncomfortable stinging. They report flares when they're exposed to sun, when they're exposed to emotional stress, when they're drinking cold or hot beverages, or when they're exposed to cold or hot weather, when they're drinking alcohol or spicy foods, or when they're exercising. Patients then, if this is continue and is not treated properly, the patients will develop edema, erythema, and also telangiectasias, which are spider veins in their face. The lay face basically is characterized by hyperplasia and hypertrophy of cheeks and nose due to inflammation and collagen deposit and sebaceous gland hyperplasia. And this is basically the rhinophyma. This is the hyperplasia and hypertrophy of the nose, and this is the flushing. And if you see all the pictures of related to rosacea, you will be able to see the spider veins. Now let's talk about discoid lupus. Discoid lupus is basically an autoimmune disorder. If you remember, it's basically the manifestation of the skin by systemic lupus. It's basically a cutaneous lupus erythematose that could be acute, subacute, or chronic. It is demonstrated by photosensitivity. Basically, the patients will have in sun-exposed areas, they would have pruritus, occasional pain, erythema of the skin. They would have red macules, papules, and fine scales, and the butterfly pattern as well. So the lesions are very characteristic. They are erythematose, papules, and plaques with slight to moderate scale. As the lesion progresses, the scale may thicken and become adherent. Patients could have hypo or hyperpigmentations of the skin. The lesions spread centrifugally, so from the center, and they grow out. As lesions age, dilation and opening of keratinocyte plaques would be able to be seen, and also patients could have atrophy of the skin as well. Let me show you a picture. This is discoid lupus. It's very like from the center to the outside. It's like a discus. Okay, it's like circular. And again, it's the cutaneous manifestations of erythematose lupus. Okay, so now let's talk about pemphigus vulgaris. Pemphigus vulgaris is also an autoimmune disease, very uncommon, but it's one of the least emergencies that are present in dermatology. is characterized by intraepidermal blisters and extensive erosions on an apparent, otherwise healthy skin, because you see that the underlying mucous membrane and the underlying skin looks healthy, but the skin is full of blister. Occurs in middle-aged patients, affecting men and women equally. Pemphigus vulgaris is characterized by IgG autoimmune disorder that is directed against calcium-dependent cat herrings. Okay, so again, patients would have bullas, which are blisters, are the primary lesions, and they cause widespread painful skin and erosions. You have here the picture of pemphigus vulgaris. Then let's talk about erythema multiforme. Erythema multiforme is also an autoimmune disorder. It's T-cell mediated inflammatory response characterized by target or iris skin lesions. Diagnosis is basically clinical. The etiology, the majority of cases are caused by herpes simple type 1, although it is unclear whether these lesions represent a specific reaction to the virus. It is for sure known that it's a T-cell mediated cytolytic reaction to the keratinocytes. Patients could have lupus as underlying disorder or hepatitis C. The symptoms could be from asymptomatic to erythematous macules, vesicles, bullas, but this is the main lesion that represents the disease. It's a bull's eye target lesion, and you could see it right there. Okay, another one that very common or similar to Lyme's disease. Epidermolysis and necrosis of the skin, it could produce as well. Now let's talk about erysipelas, folliculitis, and other bacterial infections of the skin. Erysipelas is a type of superficial cellulitis. So it's the same as cellulitis, but cellulitis is more extended to the subcutaneous tissue, and erysipelas is a cellulitis but superficial. So it is characterized by raised, shiny, indurated, tender plaque with very distinct margins. Is produced by streptococci, beta hemolytic, but it could be caused by other type of bacterial infections. Patients would have the skin red, swollen, with patches that spread rapidly, and also would have systemic manifestations of infectious processes such as fever, worm, erythema, leukocytosis, chills, etc. If we talk about cellulitis to compare, again, this is a deeper form of acute bacterial infection of the skin and subcutaneous tissue that is also caused by streptococci or staphylococci. And the symptoms are very similar, but they tend to spread more rapidly into erythema and edema, causing fever, lymphadenopathies. The diagnosis is basically by clinical appearance and also by cultures. Now let's talk about other signs and symptoms that could be present systemic in cellulitis and erysipelas are hypotension, delirium, and also skin sloughing. You will learn about how to treat cellulitis in pharmacology. Now let's talk about folliculitis. And folliculitis, it basically is a bacterial infection of a hair follicle individually, one by one, when furuncles is a group of follicles that are infected, and carbuncles is a plaque, is thousands of follicles that are infected. So folliculitis is usually caused by Staphylococci aureus, even though it could be caused by other organisms when the patients are immunocompromised, such as in diabetes, for example, or any other autoimmune diseases, superimposed infections with Pseudomonas. In folliculitis, the patients would have pain, pruritus, and irritation. It's basically an ingrown hair that has a pustule surrounded by the inflammatory process of the hair follicle. Furuncles, on the other part, and carbuncles, this is a group. Furuncle is a boil, and carbuncle is a plaque of hair follicles that are infected. It's exactly the same is an infection of Staphylococci infection of hair follicles and surrounding tissue. And the carbuncles are clusters or furuncles that are connected together subcutaneously, forming a huge plaque. Very painful, as you could imagine. It could appear anywhere, in the neck, in the breast, in the face, in the buttocks, in the nose, anywhere. If you look at the pictures, this is erysipelas. Let's talk about cellulitis. Cellulitis could also occur anywhere, most likely unilateral, but it could be bilateral, in the elbow, in the leg, in orbital cellulitis in the face. Okay, this is folliculitis, individually one by one. When this is a furuncle or boil, aquí many hair follicles are infected at the same time, and this is a plaque of furuncles connected underneath the subcutaneous tissue by Staphylococci infection. So again, individually, a group, and a plaque of furuncles. Okay, impetigo. Let's continue to talk about bacterial infections. So in impetigo, this is basically a streptococci pyogenes infection that is very common in pediatric population, even though it could be present in adulthood as well. Patients could have also a staphylococci infection. There is no need to be any predisposing lesion, but general risk are moist environment, poor hygiene, and chronic nasopharyngeal carriage of the staph or the strep. And the main symptoms are characterized by vesicles, that when these vesicles break, they produce a honey color crust, which is a hallmark for impetigo. Very contagious and is very common presently in daycares, patients that are wrestling, very close contact with the skin. Okay, and you would see that the main treatment is the antibiotic. Now let's talk about viral infections. This is basically herpes virus family, that after an initial infection of all herpes virus remain latent within specific host cell and may subsequently reactivate. And this is the case of having chickenpox, and then you have herpes zoster. So let's talk first about, we're going to discuss today herpes simple, varicella zoster, and molluscus contagiosus, and other disease processes of the pediatric patients. If you remember, in herpes simplex virus, you have type 1 and type 2 that commonly cause recurrent infections affecting the skin, the mouth, and the genitals, even though it could produce severe infections such as encephalitis and meningitis in immunocompromised patients. If you remember, the herpes virus that is simplex, in the past it used to be said that for the mouth and the lip it was type 1, and for the genital was type 2. This is not applied anymore. You could have either or, herpes 2 in the mouth and herpes 1 in the genitals. So the order does not alter. Patients that after an initial infection, the herpes remains dormant in the nerve ganglia, and from which it can periodically emerge, causing symptoms. Most likely it's precipitated when the patient have exposure to sunlight, febrile illnesses, or stress or immunosuppressive moments, such as prolonged use of antibiotics, etc. And so basically, what would the patient feel? It will feel a tingling or burning sensation first as a prodrome, and then the patients would have the appearance of small painful vesicle, single or a group of vesicle that is associated with adenopathies. It could have low-grade fever, low-grade leukocytosis, and if it's genital, it could be associated by painful urination or dysuria, and also vaginal discharge. And you would see that it's treated by antiviral infection. Then let's talk about chickenpox. This is also a herpes virus that is most commonly when it's an acute systemic produced as a childhood infection if you're not vaccinated. But it could also be present in adolescence and early adulthood, although it's rare. Usually begins with mild constitutional symptoms of flu-like symptoms that are followed by a group of crops of vesicles that rupture and crust. Some patients, again, if you're immunocompromised, they could have alteration of neurological system. So in the immunocompetent children, chickenpox complications are rare. Initial rash with macular eruption that tends to coalesce, but basically it's vesicles that rupture and form a crust. In adulthood, when this chickenpox patients are immunosuppressed by some reason, they could develop herpes zoster. For example, in patients that are diabetics, or in patients that have HIV, or patients that are in systemic antibiotic use, prolonged. Okay, so this is herpes simplex. This is chickenpox. You see the group of vesicles there. And then herpes zosters, again, is basically the reactivation of the varicella or chickenpox that was dormant in the nerve ganglia. And once the patient has an immunosuppressive condition, or the elderly, which the immune system is already compromised or decreased, this group of vesicles along the dermatome distribution emerge. It could be ophthalmic, it could be intercostal, it could be cervical or sacral, and it's also treated by antiviral. And it could give you a lot of pain, leaving behind a complication that is called postherpetic neuralgia. Let me show you a picture first of herpes zoster. See a group of vesicles along the dermatome distribution. Now let's talk about molluscum contagiosum. Molluscum contagiosum is a cluster of pink dome-shaped, smooth, waxy, and pearly, but most commonly the key word here is umbilicated. Umbilicated papules that is caused by a virus which is called pox virus. Very common in children or immunocompromised patients. So if you see it in children, it's okay, it's common, but it's also contagious. If you see it in adults, it's because that adult has the immune system compromised. Could be from a simple diabetes or autoimmune disease up to HIV. So you must test the patient with HIV. It's self-limited, so it goes away in the children, but it's contagious. It's produced by close contact or auto-inoculation. Causes localized chronic infection. Transmission, again, is by direct contact. The spread occurs by towels, bath sponges, bath water if you're reusing the same leftover water. For example, in underdeveloped countries that you shower with, you put the water in a container. Molluscus contagiosus is very common in children. It is acquired by close skin contact with an infected person, such as sexual contact or wrestling as well. But again, be very alert if you see it in adulthood. It could be corticosteroids induced, it could be chemotherapy, but it could also be HIV. It is diagnosed by biopsy, even though it's typical, and is treated by cryotherapy, curettage, or laser ablation. And here you see another example of molluscus contagiosus is umbilicated. Now let's talk about the difference between rubella, rubeola, which is more or less the same, it's interchangeable, German measles or measles, rubella, rubeola, the same. What is not the same is roseola and varicella. So besides the incubation period, you have to concentrate on the rash type. In rubella and rubeola, these patients have a maculopapular rash that tend to coalesce. Patients have prodromal symptoms of flu-like symptoms such as fever, malaise, and also barking cough. In addition, in rubella or rubeola, there's a pathognomonic lesion in the mouth, which is called couplet spots. And I'll show it to you now. Roseola, on the contrary, has a macular papular rash, and a patient, or it's also called exanthema subitum. That means that rash fast onset. So the baby had normal, healthy looking, all of a sudden develops a high fever, and after a high fever, the rash comes out. And we already discussed about varicella. So if you look here, this is a rubella, it's a maculopapular rash, and this is the couplet spot, and this is the roseola. What is basically very, very common produced is the fever followed by this sudden onset of rash. Okay. Here you see all the pictures of the couplet spot and the subitum exanthema or exanthema subitum. So again, measles is a viral condition, very common in children, is characterized by fever, couplet spot on the oral mucosa. The pathophysiology is a paramyxovirus. Transmission is typically by respiratory droplets, and the signs and symptoms after the incubation period, patients have fever, hacking cough, they could have conjunctivitis, but then this patient has a rash, maculopapular, that spreads to the trunk and the extremities, that includes the palms and the soles, has a hacking cough, extensive prostration, they have high fever as well, and they have the presence of the couplet spots. Before we go into the tinnitus, basically is indications or treatment for that is antiviral. Now let's talk about tinnitus. It's basically called dermatophytosis, and these are fungal infections of the keratin that could include the skin and the nails. Let's talk first about tinea capitis. Basically is a fungal infection of the scalp that has round patches of dried scale and alopecia. The difference between alopecia areata and alopecia due to tinea is that the base of the hair follicles are the hair shaft are broken and they look ill. The hair follicle looks ill. Alopecia areata, you have healthy skin in the area that there's no hair. Tinea corporis is another type of fungal infection that is produced by the same type of fungi or dermatophyte, that basically the patients would have pink to red annular patches. These are called the ringworms, and it's diagnosed basically by KOH. You scrape the lesion and you get some scales from the border, and you put it in a slide and you see the microsporum. It could also be diagnosed with woodlight and fungal cultures, and you would see the treatment are the azoles family. So the itraconazole, the fluconazole, which is Lamisil and Sporanox, as well as creams. Candida or intertrigger. Oh, the dermatophytosis or tinea could be present in the scalp, called tinea capitis. Could be present in the body, which is called tinea corporis. If it's present in the nails, it's called tinea unguio or onychomycosis. If it's present in the inguinal area, it's called cruris. If it's present in the hands, it's called tinea manus. If it's present in the beard, it's called barba. And if it's present by a different type of microsporum, which is called Malassezia furfur, is called versicolor. But it's basically round, oval, erythematous patch that are present in the skin or any type of area of the scalp that is called ringworms. Candida, on the contrary, is another type of fungi. It's called moniliasis. It's called basically produced by Candida albicans that could produce infections at any point in the skin, including the skin folds, the digital web spaces, the genital, and the oral mucosa. The signs and symptoms of Candida, if you see it in the mouth, for example, is a white cheesy like plaques. If it's present in the vagina or genital areas, you see that cheesy looking discharge. So it's basically very pruritic, itching. It's erythematous patches, well demarcated, with satellite pustules. These are the tinea corporis or ringworms. This is the tinea capitis. This is the tinea versicolor. This is the tinea cruris. You basically treat them with antifungal solutions. Let's leave it here. We're going to take a break and then finish the rest of the slides in a second PowerPoint, because otherwise it won't fit.